Greetings, my name is James Wright. I'm a graduate student in the Economic, Social, and Administrative Pharmacy program at Florida A&M University in Tallahassee, Florida. If you need to contact me with any questions regarding the presentation or any information you'd like me to provide, you can see my email address right here on this slide here. So a few things about ARDS. ARDS stands for acute respiratory distress syndrome, and it has a host of different causes such as drug overdose, oxygen toxicity, shock, aspiration, pulmonary ischemia. Normally, treatment calls for oxygen therapy, lung expansion measures such as the use of positive end expiratory pressure, we call it PEEP, and also mechanical ventilation that utilizes high rates and low tidal volumes, and this is done for lung protective purposes. Depending on the severity of the ARDS, a patient being treated with these modalities alone, it might not be enough and they can enter a state of refractory hypoxemia. And so this is where prone positioning comes into play. Prone positioning allows for the improvement of ventilation perfusion matching, also an increase in end expiratory lung volumes. It also helps with limiting ventilator-associated lung injury by allowing a more uniform distribution of pulmonary gases through alveolar recruitment. So the specific aims of my study was to compare the amount of time spent in ICU, the number of deaths, or mortality, and the number of cases of ventilator-associated pneumonia with each modality, so prone positioning and supine positioning. My primary outcome was ICU, or days spent in ICU. My secondary outcomes were mortality and VAP, ventilator-associated pneumonia. So for finding relevant studies, I just searched relevant electronic databases utilizing key terms such as ARDS, prone positioning, supine positioning, what else? Mortality, ventilator-associated pneumonia. And with utilizing the meta-analysis, I use RevMan and Excel. And anything related to COVID-19 was excluded at this time. So if we go down to our mean ICU days, focusing right here on the bottom, we can see for our average, it doesn't vary by much. Honestly, just one day when you look at prone positioning and supine positioning. If we look at mortality, we can see our percentage that died and our percentage that died for prone positioning right here and our percentage for supine positioning. So we can see an advantage there for prone positioning. For ventilator-associated pneumonia cases, it didn't vary by much. The study by Urine and others didn't have any ventilator-associated pneumonia cases that they included in the results, so I didn't include it. So for our forest plots here, we can see that for mean ICU days, there wasn't anything statistically significant occurring. If we go down to our forest plot for mortality, though, we can see that it favors prone positioning. We can see that it is statistically significant when we look at prone positioning, and that's due to Urine and others. Their weight of their study actually accounted for the pool of some effects being pulled towards the prone side and favoring the prone positioning. For ventilator-associated pneumonia, as we can see here, there's nothing statistically significant occurring. So with more time, with more research, and with more practitioner education, I think prone positioning has potential to be used as a first-line defense. We have patients that are suffering from acute, respiratory failure that is refractory, or ARDS as refractory to just conventional means of mechanical ventilation. Thank you.